Okay, now we have Dr. Corollos Kamal Hakim. The topic with the title Management of a High Angle Class 2 Case with Severe Crowding. Welcome, thank you.
Good afternoon. First of all, I would like to thank all my colleagues for their amazing presentations, and I'd like to thank you all for being here and attending this lecture. And I'm very honored to be part of the ETSIC. Let me introduce myself. I am Dr. Crowding Hakim. I graduated from the University of Dundee in Scotland, in the UK, with a Master of Science in Orthodontics. This is a map of the UK, and it's located in this dot, where is Edinburgh and Dundee city in Edinburgh. This is the city of Edinburgh, and this is me graduating from the university with the graduation donut, they call it, and I noticed how bold I am being. I'm also a member in the British Orthodontic Society and the founder of my center, Pure Orthodontics, in Asyut City, in Upper Egypt. And I'm also an international credentialed volunteer with Operation Smile, which is an international organization for treating cleft lip and palate cases. Let's get to the case. So my case summary, SA is a 13-year-old Egyptian female patient, which is fit and well medically. She presented complaining from squint teeth, and she doesn't like her smile. The case showed a class 1 incisor relationship on a mild skeletal class 2 base with increased vertical proportions, which was the challenging part of the case. The malocclusion was complicated with mild crowding in the upper arch and severe crowding in the lower arch, which was more than 8 millimeters. And she had, of course, a class 2 canines on both sides and a class 1 in molar relationships. Let's go to the extraoral pre-treatment assessment photos. So this is my case. The case was consented, was written consented to show her photos. Going to the first frontal photo with examination, we draw 3 lines to assess the vertical proportions of the case. The lower third was significantly increased due to the increased vertical proportion of the case. The midline, the upper central line, was coincident with the facial midline, and the smile of the patient was consonant with the lower lip. The profile photo shows how increased the lower vertical height of the case, which was a challenging part really for anchorage demand. Drawing the zero meridian line shows the significant protrusion of the mandible in relation to the zero meridian line, which is due to backward and downward growth of the mandible, and which increases the class 2 pattern of the case. The aesthetic rickets plane shows that the lower lip is on the line, which is fine. It's not the prominent, which is due to, again, the backward and downward growth of the mandible. Drawing the Frankfurt horizontal plane and the mandibular plane shows the increased vertical dimension of the case. And this photo also shows how increased is the lower vertical height. The intraoral photos. This is a frontal photo. These are the photos. The frontal photo shows there's a midline shift in the lower arch, 2 millimeters to the left, with severely crowded lower left canine, which is completely out of arch with no space at all for it. The left buccal side shows a class 1 molar relationship and a class 2 quarter unit canines, which will be increased when extracting the lower left 4, as I will come in the treatment plan. And on the right side, there's a quarter unit or almost a half unit canine class 2 and a class 1 molar relationship with a class 1 incisor relationship with almost average overbite. This is the upper arch, shows mild crowding less than 4 millimeters, and the lower arch shows severe crowding with the lower left canine being completely out of arch and with no space at all for it. The Bolton's ratio, when measured, the overall Bolton ratio was 91%, which is slightly a bit increased, and the the anterior Bolton ratio was 78, which is again a bit increased. And this comes to the point that there was a 2-size discrepancy between the lower arch and the upper arch, which because of the small upper laterals. The small upper laterals will come against getting a perfect class 1 in canines because of the small size of the laterals. So it was not possible to gain perfect class 1 canines at the end. The panoramic radiograph assessment the radiograph in 4 circles to avoid missing any information. So the outer circle looking at the margins of the mandible and the nasal cavity and nasal flora and the sinus. You will note that the ear rings of the patient were not taken out before taking the radiograph here and in the CEF, and this because they were like permanently fixed in her ears, and of course it was unethical to get the patient into another radiograph to remove the earrings because they were not obstructing against getting a perfect diagnosis from the X-ray. It was a grade 2 X-ray, it was fine diagnosable. Looking at the bone of the mandible and the roots of the teeth, all was fine with no periapical pathosis. And the alveolar bone was all fine with no significant pockets, and the crowns were all okay with no significant caries or any other abnormalities in the crown. The lateral cephalometric radiograph. Here is a tracing of the lateral ceph, again with the earrings in place, no problem. This is the tracing, and coming to the numbers, the SNA was increased, SNB was decreased. This gives an NB of 5 degrees, which is after Eastman correction becomes 4. This again confirms the class 2 discrepancy, which is mild. The SN maxillary plane 8.6. The maxillary mandibular plane angle was the most important one, which is 38. This confirms the increased and the high angle nature of the case, with increased lower anterior facial height, and the upper incisors to maxillary plane was 119. That's proclined. They are proclined, and the lower incisors were 85.5, which is a very bit proclined, not too much in relation to the MMBA, because when you have a high angle case, the lower incisors tend to retrocline a bit and to become in a normal range to compensate for the downward growth of the case. And they were proclined because to compensate for the class 2 discrepancy of the case. The A point to McNamara, when we measure in millimeters from the A point to a McNamara line, which is a perpendicular line from the nasum point, it's 4 millimeters, which again confirms the SNA of 83, which is a bit prognathism of the maxilla. And the Begonian point to McNamara is a minus 1.5, which confirms the retruded position of the mandible due to the lower, due to the backward and downward growth and the high angle of the case. Going into treatment planning, the problem list, we had mild generalized gingivitis and mild superficial caries at the 6s. We had mild hypoplasia affecting the lower left lateral and central. Of course, mild class 2 the skeletal discrepancy, severe crowding in the lower arch, mild in the upper arch, class 2 half unit on the right side and quarter unit on the left side canines, and the midline shift in the lower arch 2 millimeters to the left, and tendency to crossbite at the lower left 5 and buccal crossbite at the lower right 5. Our aims of treatment is to establish and maintain good oral hygiene and restore all the carious lesions in the 6s significantly, and they were not very significantly carious, and monitor the hypoplasia, the hypoplastic region to ensure good oral hygiene, accept the class 2 skeletal discrepancy, and relieve the crowding, of course, and establish leveled and well-aligned arches, correct the central lines shifts, and establish class 1 incisors, molars, and canine, and of course retain the results afterwards. Our treatment plan was, first of all, referral to a general dental practitioner to restore the 6s and maintain oral hygiene. The treatment modality was camouflage orthodontic treatment. We didn't go to surgical option because of the mild skeletal discrepancy of the case. Extraction treatment of lower 4s and upper 4s. And appliances, we used an MPT appliance prescription pre-adjusted edgewise 22 by 28 slot. This is because the lower, because of the negative 6 torque in the lower incisor in the MPT prescription, and the +3 tip in the canines, which will prevent further proclination of the lower incisors. Anchorage was through a transpalatal arch in the upper arch and using a mini screw on the upper left side to reinforce anchorage, because the anchorage management of this case was the difficult part because of the high angle nature of the case. And then a bonded retainer in the lower arch and vacuum formed retainer in the upper arch. The start of treatment, first of all, we started leveling and alignment. We started to open space for the lower left lateral and retracting the canine in the extraction space of the lower left 4. We had our TBA in place, and we had our mini screw the laser is not working, sorry. We have our mini screw here. We have indirect anchors through the mini screw to the 5, ligating the upper left 5 with the mini screw to hold it in place, not to move mesial, and then retract the canine indirectly on the 6 to gain all the space, because we want to get all the space distal to canine with retraction to reach a class 1 canine. The lower left canine will not need much distal movement because we had a 2 millimeter midline shift to the left. So when we move the lower segment, the lower anterior segment to the right, the lower left canine will almost remain in its place. So we don't need to retract the lower left canine a lot. After opening space to the lower left central, we started using crimpable hooks on the upper arch. I used two-step canine retraction, like Dr. Abu Bakr was talking in his lecture like 2 hours ago. There was no real difference between using a two-step or a single-step retraction, but actually I was afraid to lose anchorage on the upper right side because I have no mini screw on the upper right side. So I decided to use a two-step retraction instead of unmasked retraction. Actually, according to an evidence-based systematic review by Rizk et al., Dr. Momin Rizk, he is my friend. He published it in 2018, and it says that there is no difference between unmasked retraction and two-step retraction in regard of anchorage loss, anchorage control. Then we, after closing all the spaces, we almost reached class 1 canines, just a bit super class 1, a bit class 2, because of the Bolton discrepancy, as we mentioned. We started to use finishing bends to correct the mesial tip of the upper left 5 and upper right 5 on a 16 stainless steel arch wire. And of course, we removed the TBA because it's no longer needed, as we have already closed all the spaces. Near end, this is the near end panorama. It's not justified really to take a near end panorama, but we took it to see how parallel the roots are. And for the near end lateral ceph and the tracing, quickly I will go through the changes. The SNA decreased a bit because of the retroclination that happened to the upper incisors, which causes bone remodeling in front of it, and the A point gets reduced. And we have an A and B of 4 instead of 5, which is improvement in the skeletal discrepancy. And the most important thing is the MMBA, which became 41. This is because the continuous growth of the case that brings the mandible more downward and forward and increasing the angle of the case. This is a superimposition of the two lateral cephalometries that shows the backward and downward growth of the mandible, retraction of the upper incisors, and the palatal and the maxillary superimposition. We show this shows the retroclination of the upper incisor after treatment, and the black lines are before and the red lines are after. Okay, in the lower arch, we maintain the position of the lower incisors. Then, immediately after debonding the case, reached the midlines were coincident. The canines were almost perfectly class 1, just a little bit because of the Bolton discrepancy. It needed a bit of settlement in the left buccal segment, which was thought to be settled after having its retainer. And of course, immediately after the bond, we still have some gingivitis because of the TBA, and we have our lower fixed retainer. The extraoral photos were all aligned and perfect. The increased gummy smile was because of the increased vertical height of the case and the growth of the mandible downward and backward, which was compensated by growth of the maxilla downward. This was discussed with the patient before treatment that she might need a surgery to correct her gummy smile because she had longer incisors and we cannot go for gingivectomy or such things. And the patient was happy and agreed to end treatment. This brings me to the end of the lecture. Thank you. Thank you very much.
Thank you, Dr. Carolus. You mentioned that why you accept a mild skeletal class 2? Why?
Actually, we had two options: either to go through to a surgery to correct the mild discrepancy, or to camouflage the case. The discrepancy between the upper and lower arch was mild. It just was an A and B of 5.
Why you don't use fixed functional to correct
because, yeah,
class 2?
We could have used fixed functional appliance, okay, but the patient was 13 years old.
13?
Yes, fixed function might work. due to the severe crowding in the lower arch, we decided to extract and accept this just mild skeletal discrepancy. It was not like severe or even moderate skeletal discrepancy, and was happy by the patient to accept such a discrepancy.
What about the gummy smile that
Yes.
increased?
Yeah, the gummy
after
smile.
It is a problem. It is a
Yeah.
real problem.
Yeah, actually, we need to understand the etiology of the gummy smile, why it increased.
We want to see before and after in one.
Okay, it might be difficult to do this now.
Yes, not now.
It
not
will
now.
suck.
It's
Yeah, okay.
It's okay.
Yeah, I know that the gummy smile increased. That's true. Why did this happen? Because the continuous growth of the mandible backward, which is compensated by downward growth of the maxilla, this increases the gummy smile. This maybe could have been prevented by posterior intrusion in the upper arch to have an auto rotation of the mandible.
And finishing of occlusion, settling of occlusion.
Yeah.
All this can.
Yeah.
You told us that the lateral inside the upper laterals was too small.
Yes.
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 Why we compensate and reshaping of the laterals?
Yes. Yes. It was consulted with the patient.
To obtain class
A perfect class 1 canines, yes.
Yes.
This was discussed with the patient. Either she wants to reach a perfect class 1 and then build up the laterals with the restoration. Yes, honestly, the patient refused to have any restorations, and she accepted like a mild class 2 canines, and she refused to have further. She told me like this: "Please, doctor, close all the spaces. I don't want to have restoration in my front teeth."
It's okay. It's a nice work.
Thank you very much. Thank you.